Hi everyone, welcome. So we're going to start off with cardiology. So starting off with ECG. Now this is the basic ECG anatomy. Now the reason ECG is there is because it's quite important for exam. So basic things for ECG we'll go over. P wave. So we all know P wave is atrial contraction, QRS ventricular contraction, and this is the T wave. So certain things we need to know for the exam. So number one, T wave, we need to know hyperkalemia. Hyperkalemia, so as I'm speaking, you can make notes. Hyperkalemia will have tall T wave. Very, very important for exam, hyperkalemia. You need to know hyperkalemia management as well. T wave, again, hypokalemia, T wave inversion. So it's called U wave. Hypokalemia, you have it, U wave. We'll do it later on again. Again, we need to know this. This is the QRS, as I mentioned to you. QRS is ventricular contraction. It should be 2 to 3 small squares. Important to know. 2 to 3 small squares. Ventricular, this QRS here. And the reason is because certain pathologies, like SVT, will be narrow. Left bundle branch block, right bundle branch block will be wide. Okay. So with just a quick note on LBB. New LBB in a patient will be STEMI. We'll do again, so you don't forget. So new LBB, if a patient, imagine if a patient comes in and they have a chest pain, and we have a previous ECG which is normal. They have no LBB, no RBB, nothing like that. Now we see this patient has new LBB. Then it's classified as STEMI, ST elevation MI. Okay, so they don't have to have ST elevation to fall under STEMI. A new LBB falls under STEMI. Again, we'll do it later on. This PR interval is, you have to know the normal interval, 3 to 5 small squares. The reason because the pathology we will do, if you don't know the basics, you will get the pathology, the disease wrong. So heart blocks. First degree heart block, for example, second degree heart block. It's important to know the normal interval for the PR intervals. 3 to 5 small squares, yeah. Okay. So moving on to the heart rate. Now there are different ways of calculating the heart rate. The way I want to teach, or I like to remember, is 300. So if you learn 300, okay. So 300 is important. Yeah.
Yeah, you can move it. I'll tell you.
Is it okay? Can you see?
No.
Yeah. Okay, sure. So 300 is important. So basically, as you can see, this is one QRS complex, one QRS complex. Okay. Between them two, you calculate the large boxes. In here is 1, 2, 3, 4. So 300 divided by X. What is X? X is the number of large boxes. In this case, it's going to be 4. So the answer is going to be 75. So ECG rhythm, very simple, 300 divided by X. X is going to be the number of large boxes between the QRS complexes. The problem with this only works if the rhythm is regular. If the rhythm is regular. But in the exam, you don't have much time, so you can use this to have an average idea, just a rough idea what sort of heart rate you are looking at. Asystole. So we all know asystole, a flat line. Okay? So in here, asystole, we have to make sure that the patient has no pulse. So this is a diagnosis based on 2 things. One is ECG finding, make sure that the monitors are attached to the patient. Okay. Number 2, you feel that there's no pulse. You have to have these 2 things there. Management, a patient with asystole, IV, adrenaline IV, very important, has to be IV. Many mistakes in Plab 2, I'm not sure why they make it, anaphylaxis and And asystole, yeah. Anaphylaxis is always IM. Because of some sort of very, very nervous in Plab 2, they always sort of, patient coming with anaphylaxis, they give IV. IV is only for cardiac arrest. Okay, so key differences here. IV adrenaline, common mistake in Plab 2. So flat line, making sure that the monitor is attached, the patient has no pulse. Moving on to ventricular tachycardia. So as you can see, this is the QRS complex. Ventricular tachycardia. It is defined as 3 or more consecutive ventricular beat more than 100 per minute. So as you can see here, this is ventricle, isn't it? QRS. So it's defined as 3 or more, in here all of them, consecutive heartbeat more than 100. More than 100 beats per minute. That's the definition. So the question is ventricular tachycardia and ventricular fibrillation. So all fibrillation is going to be irregular. So VF, you're going to have it irregular. VT is going to be regular. So how to tell the differentiation between VF and VT is going to be easily. VF will be irregular, VT will be regular. So this is VT. Very, very important thing here. After heart attack, we'll do again in the other chapters coming up. A person has a heart attack within 48 hours. If they have palpitation, in the exam palpitation, always think, could it be VT? It's very common. VT. A complication after heart attack to know for the exam is ventricular tachycardia. Key thing to highlight here. So you have to know how VT looks like. Because this will be a ECG that they will ask you in the exam, VT. Management of VT depends. There's 2 pathways. Number 1, does the patient have a pulse or no pulse? If the patient has a pulse, that's different. If the patient has no pulse, different. So if the pulse is absent, okay, very simple, it goes into ALS algorithm, we treat it as same as VF. So this patient will need a shock. Exam focus for Plab 1, they ask you mainly when the pulse is present. Patient has a VT, has a pulse. What do you do? It depends. Is the patient stable or unstable? So VT depends. Stable or unstable. If the patient is stable, amiodarone, IV amiodarone. You need to know this one. VT, stable, IV amiodarone. With amiodarone, please know, it can cause hyperthyroidism and hypothyroidism. Both of them. It can cause hyperthyroidism or hypo. That's why for monitoring this patient, we need to monitor regularly their thyroid function test. Key thing for exam, TFTs. So amiodarone can cause hyper or hypo. We need to monitor their TFTs, thyroid function test. If the patient is unstable and has a VT, and has a pulse, but it's unstable. Unstable means what? Systolic under 90. Okay? Not 90, under 90. One mistake they make in pneumonia, curb 65, the BP is not 90. Systolic is under 90, diastolic is 60 or less. So just a diversion, patient has a curb 65 to make the score. Obviously you have the respirate, urea and so on. One of them is blood pressure. So if the systolic is less than 90, for example 89, that will count. If it's 90, it will not count. Diastolic, if it's 60 or less. No, it's just an example. Okay. In here, if a patient is unstable, would have been systolic under 90. Heart rate more than 150. Heart rate more than 150. Number 3 is the patient has a chest pain. Number 4, evidence of heart failure. These will indicate the patient is unstable. For this one, we need to shock the patient. So VT management, very important. Okay, VT on ECG, pulse is present. 2 management, stable or unstable. SVT, supraventricular tachycardia. So SVT is very, very important. You need to know how SVT looks like in the exam. This ECG is very important. You need to know how SVT, because that's one of the questions they will ask you, SVT, recognizing SVT purely based on ECG finding. So this is an SVT. Now under SVT, you need to know the management of SVT. So we'll do this later on in more detail. So just a sort of quick summary going over SVT for ECG basics. Moving on to atrial fibrillation. Okay. So in atrial fibrillation, the patient has no P wave. And obviously you have fibrillation. Number two, as you can see here, this is very irregular. Okay, these sort of lengths are irregular. So AF, irregular. If you have a patient who's got SVT and you see the rhythm is irregular, you know the underlying cause is going to be atrial fibrillation. So remember I mentioned to you, all fibrillation is going to be irregular. So VF, irregular. AF, irregular. AF management we'll do it later on, but basically let's go over it just quickly here. So if a patient has AF, key thing for the exam is going to be rate controlling. How do you rate control? Obviously AF will be fast. Okay, so fast AF, how do you rate control? So in the exam you'll have a heart rate, fast heart rate. Now rate controlling is based on these medication, very important. So beta blocker can be used, CCB can be used, or digoxin. So these two are your first lines, these two, beta blocker and calcium channel blocker. If the patient, so now you choose it based on patient's medical history. If the patient has asthma, you can't give them beta blocker, so therefore you give them calcium channel blocker. One thing to understand about this one, actually we'll do it later on. Next one is going to be digoxin. If a patient has AF and a background of heart failure, or they have heart failure, then you will give digoxin. Why? Because this will decrease the heart rate and is also positive inotropic. It helps with the heart contraction. So you are helping with the heart failure and you're also helping with the AF. So you kill two birds with one stone. So if a patient has this, very key thing for the exam is digoxin, when to use it. Heart failure. These two based on do they have asthma or not. With all AF, as we know, AF can cause a clot in the atrium, can dislodge and can cause stroke. So therefore, these patients need to be anticoagulated on warfarin. INR should be 2 to 3 to prevent embolism. This is the scoring we do. When a patient has AF, we need to score them, meaning how high risk they have for having a sort of a clot of causing a stroke. So CHAD VAS2, so this is the score for AF. Also, when we want to start a patient on anticoagulation, number one, we do the scoring here, I mentioned to you here, for AF. And also we do a Hasbled score. Hasbled score basically is a scoring to see what is the risk of them bleeding. So there's one thing, is that what is their risk, how risk are they for having a clot, and how risk are they for having a bleed out from giving the anticoagulation. So we balance the two out to see an idea of the patient, should we start him on anticoagulation or not? It gives us a rough idea, and should we discuss with seniors, should we involve the other speciality, have they got high risk bleeding? So this is the score we do for when we want to start them on anticoagulation. This AF here, paroxysmal AF, so it self-terminates within 48 hours. So it's not always there. So if a patient has a palpitation, okay, and we do an ECG and they don't have AF, it does not mean there's no AF. It could be this one here, where it comes and goes, right? So therefore, we need to do a 24-hour ECG monitoring to make sure that we pick up this AF. So it's paroxysmal. So it self-termination within 48 hours. For the exam, you need to know this one. Class 1 anti-arrhythmic drugs. This basically it prevents the relapse, the frequency of having AF. So flecainide, propafenone, these are the two medication we need to know for the exam. For paroxysmal AF. So it's not your beta blocker, it's not your Hashimoto blocker. In here, for this one, they'll ask you about these two medication to which decreases the relapse of AF. These patients, even though it's not all the time, you need to anticoagulate them. They still have a risk of having a stroke, having a clot causing a stroke. Acute AF. So let's give a scenario. Just say patient X, a patient 48-year-old man comes to A&E with palpitation and he's got AF. What do we do? So it depends. It depends on two things. When did it start and how stable are they? That's a two management thing. So if the patient is unstable, so number one, if they had an AF, the time factor, if it's 48 hours or less. So if you have the heart here, let's put the heart here, and if you have an AF here, this fibrillation, basically your atrium is not contracting. So the blood sort of remains in one area, stasis. For example, if you go into a long flight, your blood pools down, isn't it? And if it's in one place, it begins to clot. The same with the heart. So in the atrium, when the blood is not really moving around in the atrium, because of the, it's just fibrillating, it's not contracting, then it can cause a clot, isn't it? Okay? Now, that's why we say this 48-hour rule. If it's less than or equal to 48 hours rule, there is less chances that it has already formed a clot. So therefore, we can sort of do cardioversion. What's cardioversion? Basically, now the heart is going to pump properly. So if there's a clot here, that will dislodge, isn't it? With it as well. So this is the rule, 48 hours, okay? So if the patient is within those hours and they are unstable, we can do cardioversion, okay?
Within 48 hours we do cardioversion.
Yeah,
After 48 hours.
yeah. So the exam patient coming with 48 hours or less with AF and they are unstable. Any patient with, for example, imagine I have AF, okay? I go to A&E, I'm stable. I will not have cardioversion. Because there's a high risk, there's still a risk, there's a clot there, okay? So in practice, we don't really do cardioversion for anyone, okay? There's a risk that there could be a clot there. But it's for unstable patient. We do a cardioversion. Given for the exam purposes, you need to know this one. Less than 48 hours, so 48 or less, cardioversion if unstable. Second thing they ask in the exam, rate controlling, okay? Rate controlling is very fast AF. Fast AF, we need to rate control them so it decreases the heart rate. These medications are very, very important. I mentioned to you guys, these two are the first line based on patient medical history. Digoxin is going to be used if the patient has a background of heart failure. Now the question arises, if the patient comes to hospital and they have AF, but it's been more than 48 hours, what do we do? Okay, so we will do that later on. So if it's more than 48 hours, actually it's just small points here. If it's more than 48 hours, what do you do? Now the problem is what? What's the problem? The problem is that we are very worried about the clot because it's more than 48 hours. Okay, so if you do cardioversion, then you can dislodge it and cause a stroke. Okay, so and that's going to be very bad, right? And you might go jail for that, okay? Causing a stroke. So what do you do? If the patient is stable, basically don't do any cardioversion, okay? Basically just sort of rough guideline. For a few weeks, we have to give them anticoagulation, make sure the blood is thinned out, and after a few weeks, by 3-4 weeks, then we do cardioversion. So few weeks, we make sure that we're clear. They're already anticoagulated. Then we do the cardioversion. Few weeks, okay? If the patient is more than 48 hours, but they are unstable, so you can't wait for these sort of 4 weeks or 3 weeks of anticoagulation. Patients are going to die in a few minutes. What do? They will not ask you in the exam mainly. It's not a common question in the exam. If it's more than 48 hours, patient unstable, we shock them. Okay, but before shocking them, we give them low with heparin, okay, to make sure that at least we do something to anticoagulate them in that moment. Yeah. So hyperkalemia ECG, very important for exam. So we know that. So what the question we'll do afterwards. Yeah. So hyperkalemia, tall T wave. So tall tented T wave. For the exam, you need to know this hyperkalemia. ECG finding. Number 2, management. Management of hyperkalemia. So in here, so peaked, tall, tented T wave, management. First thing you do when they ask in the exam, what is the initial you think you do for the hyperkalemia? Is number 1, 10% calcium gluconate. This will not do anything with the potassium. It will not decrease or increase. Has no effect on potassium. It's just to protect the heart from arrhythmia. So number 1 is going to be 10% calcium gluconate. After you have done that, that's the first thing you do. Then you'll go to insulin and dextrose. Insulin will decrease the potassium and insulin will cause hypoglycemia. That's why we add the sugar. If still not going down, nebulize salbutamol. After you have given these management and it is still not going down, it is resistant to treatment, then dialysis. Very important for exam. Dialysis when? If they have done 1, 2, the answer will not be dialysis. You have to have nebulized salbutamol. So in the exam, when they ask you what is the initial management, it's going to be number 1, calcium gluconate. What is, if they say the most appropriate, it's going to be insulin dextrose. So what does that mean? So initial, what will you do first? Most appropriate mean what will, in theory, help that condition. It's going to be to decrease the potassium, which will be your insulin and dextrose. So dialysis, don't forget when to do it. Okay? You do it after you have done these 3 and it is resistant to the treatment, resistant to medical treatment. Then you have to call the renal team for urgent dialysis. So this is a U wave here. So in the beginning I mentioned about hypokalemia. I sort of accidentally said it's T wave inversion. It's not. So T wave inversion is for ischemia. Okay. So hypokalemia is a U wave. So as you can see, this is a P wave, QRS, T, and another wave here that's called the U wave. Okay. This is a T wave inversion. T wave means ischemia. So I made a mistake in the beginning. Just so if so hypokalemia, U wave here. You also have other things as well here, but for the exam purposes, just learn the U wave. Hypokalemia. What things can cause hypokalemia? You need to know for the exam. Number 1, Conn syndrome. So we'll do this in endocrine. Conn syndrome, you have high amount of aldosterone. Okay, so Conn syndrome, you have a high aldosterone, and as we know, aldosterone acts on the kidney, and it sort of increases the sodium reabsorption and secretes potassium. So in Conns, we're going to have high sodium and low potassium. So any patient in the exam, you see, patient has hypertension and this abnormality, high sodium, low potassium is Conns. So you need to know this, which one is which. So in Conns, you're going to have high sodium, low potassium plus hypertension. Diuretics can also cause hypokalemia, but it also cause hyponatremia. So you have low sodium plus low potassium. If the patient is vomiting, diarrhea, regardless, hypokalemia. Pyloric stenosis, gastroenteritis, hypokalemia. STEMI. So in the ECG, as you can see, this is the ST elevation here, ST elevation here. So STEMI is ST elevation MI. Management, we'll do this in the next coming pages. I want to focus on here, PCI. So when a patient comes with a STEMI, Remember I said to you guys, STEMI can also be a new LBB, left bundle branch block. What do? The gold standard is going to be PCI. So if the patient comes, and the PCI can be done within 12 hours from the onset of chest pain. So you have to memorize these hours, 12 hours. From the onset of chest pain, not from admission or arrival or diagnosis, from the chest pain time, 12 hours. Important for exam, 12 hours here. Gold standard, this is the, if they say most appropriate management for STEMI, PCI, definitive or the best one, PCI. Okay. If PCI is not available, or the patient does not meet the hour criteria, thrombolize them with what? Altiplase or streptokinase, either of them. They won't give both. Okay, they won't give both. Altiplase or streptokinase. The only condition, the only case they may give you both, they may say patient had it before. Okay, then you will choose altiplase. Okay. So either of them, streptokinase or altiplase, they've both been proven to be very effective on studies. So we use either of them. Okay, and if they show the patient had it before streptokinase, avoid using that and use altiplase. But they will not give you both together with no background history. Acute pericarditis. So if someone hasn't done much ECG, they will get scared of this. They will say, oh, it's a massive heart attack. So acute pericarditis is basically widespread saddle ST elevation. So as you can see here, the ST elevation here, there, everywhere. All the red dots shows you ST elevation. It's not a STEMI, it's not a heart attack, it's acute pericarditis. Now there are several causes of this, so many causes. The most common cause is viral. For the most common cause of viral is Coxsackie virus. So please put down, Coxsackie virus is the most common cause is viral, caused by Coxsackie virus. Important for exam, Coxsackie virus. So pericarditis, so pericardium, inflammation of the pericardium. It can be caused by several things, virus, it can be caused by after heart attack, it can be caused by uremia, high urea. For example, if you have kidney failure, when you have high urea, remember high urea causes encephalopathy, can cause pericarditis and other things as well, and itchiness. So this one, you need to know the chest pain. Sitting up and leaning forward tends to ease the pain. Sitting up, very important. Sitting up and leaning forward tends to ease the pain. Treatment, NSAIDs. In here, two things for the exam. If the patient's going to have a heart attack, MI, myocardial infarction, okay? Now, it could be post-MI acute pericarditis or Dressler syndrome. Differentiation is based on time frame. If a patient has a heart attack, within the next few days, they have this, then it's going to be post-MI acute pericarditis. So few days, within few days, not weeks, few days. Post-MI acute pericarditis, if this happens after a heart attack, within the first few days. If the patient has this, they had a heart attack, after within 2 to 10 weeks, 2 to 10 weeks, they have this, then it's Dressler syndrome. So 2 to 10 weeks, not days, weeks. 2 to 10 week after. So they had a heart attack, after 2 weeks, okay, they have this, then it's going to be Dressler syndrome. Please put down symptoms. Number 1, I mentioned to you about this chest pain leaning forward thing. Number 2, low-grade fever. Low-grade fever. Number 3, very important, pericardial friction rub. Pericardial friction rub. Okay, so heart blocks. I mentioned to you that you need to know the intervals. So the PR interval was 3 to 5 small squares. With first degree heart block, which is here, this is the PR interval as you can see here. So it gets bigger and it gets sort of prolonged and prolonged. Okay? First degree heart block, PR interval is prolonged. So first degree heart block, it will not get bigger and bigger and bigger. It will be sort of constant, but so prolonged PR interval. So more than 5 small squares, prolonged PR interval. But it will not be sort of small, big, 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 small, small, not for this one, yeah? Second one, important here, you have PR interval here, as you can see. There. Can you see this one there? It gets slightly bigger there, right? Okay, so here is a P wave. PR interval here. P wave here. PR slightly bit more longer in length. Then here P wave, but there's no QRS. Then you have P wave, QRS. P wave slightly longer here, QRS. P wave more longer here. P wave, no QRS. So second degree, it gets longer and longer, then drops a beat. It's also called wanky back. Yeah. Second degree, type 1. Type 1, the PR gets longer, and then drops a beat. So you have to look for that one. Does it get longer and longer, and does it drop a beat? That's type 1. Type 2 is very simple. PR remains same. So as you can see, P wave here, QRS, that's fine. P wave here, drops a beat. Nothing there. Or actually here actually. So here you have your P wave. So P wave here, that's fine. P wave here, no QRS. So one beat dropped. P wave here, that's fine. Next P wave, dropped a beat. So the PR is not long. Okay? It's okay. It's just that it drops a beat. These two differentiation important for exam. Type 2, please put down, you need to have this patient needs a pacemaker. Type 2 pacemaker. Third degree also needs pacemaker. Third degree heart block needs a pacemaker. This patient will have bradycardia. This patient will have bradycardia, third degree. So this is serious, obviously, third degree heart block. There is no association between the QRS or the P wave. The atrium is doing its own thing, the ventricle is doing its own thing. So they are independent. So there is independent atrial and ventricular rate. There is no sort of, as you can see with these one, we have a pattern, isn't it? We have a pattern, right? We have a pattern of what's happening. With third degree, there's no pattern. It's just randomness, okay? The ventricle is doing its own thing, atrium is doing its own thing. So these patients will have bradycardia, they need a pacemaker. So second degree type 2, third degree, both of them pacemaker. Moving on to left bundle branch block. So I mentioned to you guys here, this one, new LBB is going to be classified under STEMI, ST elevation MI. LBB, as you can see here, this is the QRS, right? So LBB, RBB, we all can tell. In the exam, it will be very obvious LBB, RBB. We all know it is some sort of bundle branch block, isn't it? Bundle branch block. Agree? Yeah? Because basically, as you can see, the ventricles, they are taking longer time to contract. That's why you have the prolonged QRS. Yeah? Because there is some sort of blockage of the bundle branch. Okay? Could be left bundle branch or right bundle branch. If there's a blockage, that means it's going to take more time to go around the ventricle to contract, right? That's why the QRS is more broader. Why broader? Is taking more time to contract. Now, it depends, is it left-sided or right-sided? For the exam, left-sided, LBB, new LBB, STEMI. How to tell the difference? For the exam, I was taught by one of my seniors, Reg, in cardio, and since that day I didn't forget. So basically, you get the ECG. So as you can see here, this is the same ECG here. Okay? It's saying LBB, okay? So what you do, you turn it around like this. Okay? Now, this pointy part here, okay, is pointing left. Okay? So this will be LBB. Okay? Do this. If you turn it the wrong way around, you get it wrong. Okay? Do this. Okay? Pointy part is more towards the left. So it's LBB. So this is the ECG. Okay? ECG. Okay? What you do, you turn it this way. This pointy part, isn't it? Yeah? Is more towards the left side, right? So this is going to be left bundle branch block. Okay? Now, with the right one, this is the right. Okay? Problem is here, isn't it? All of this. Yeah? Turn around, it's more towards the right side. So it's RBB, right bundle branch block. This will work in the exam because they will give you an obvious LBB, obvious RBB. Moving on. Torsades de Pontis. So this is a VT with varying axis. So VT is associated, as you can see VT here. So varying axis. So Torsades de Pontis, as you can see, is VT, isn't it? But varying axis, yeah? Varying axis. As you can see, up and down, like a roller coaster, yeah? So Torsades de Pontis. Now, this is associated with long QT interval, may complicate MI, and risk factor can cause sudden death. For the exam, we need to know this. Management, IV magnesium. IV magnesium. Moving on to digoxin. So key thing for understanding, we understand that for digoxin, if a patient has a AF and a background of heart failure, for rate controlling, it's not your beta blocker, it's not your CCB, it's going to be digoxin because it decreases the heart and it helps with the contraction of the heart. So in here, if a patient has a digoxin toxicity, because basically digoxin has a very low therapeutic index. It's very easy, very common to have this problem, yeah? So therefore, ECG finding, it causes ST depression and TUST depression. Remember, you have your QRS and then T wave. But there's no T wave here because there is T wave inversion. So ST depression, T wave inversion. It's called like the reverse tick sign. Reverse check, or reverse tick. Okay, so I'm not sure how that makes sense. I get more confused. For me, it's more easier. ST depression, T wave inversion. That makes sense. Okay, it's depressed, then it's inversion T wave. That's digoxin toxicity. Okay, please put down there. With this patient, will have a bradycardia. Why bradycardia? Think about it. Digoxin, what does it do to the AF? Decreases the heart rate. Toxicity will cause bradycardia. So this patient may need atropine. Obviously, with bradycardia, we treat it with atropine, isn't it? Yeah. Now, if you suspect any patient with this, any patient on dig, and you suspect they have toxicity, first thing you do is use the knees. You want to check their potassium level. You want to check their potassium level. Okay. Now, digoxin toxicity signs and symptoms. Okay. So, ECG finding very, very important. It can cause a lot of arrhythmias. So, VT, VF can cause AV block, SA block. So, these are very, very important arrhythmias. Okay. Can cause blocks. You have bradycardia. Can cause complete heart block, okay, ventricular extrasystole. So a lot of things can cause, okay, ECG. That's why it's very, very important to do ECG. But don't forget your reverse tick sign, ST depression, T wave inversion on the ECG. Number 2, Important here in the exam, they'll give you, patient has nausea, vomiting, diarrhea. These three are very important. Destoxicity, nausea, vomiting, diarrhea.